Yeah, you've got 40 weeks building up to this one big moment of delivering your baby. Nothing is too small to come and see us for advice on. Why can't we talk about period problems? Why can't we talk about abnormal smears? There's still a stigma attached to that. Gosh, the biggest factor that women discuss pretty early on is around what they can eat. There are ways in which you can manage stretch marks, okay? That's a really common myth, and one which some people may want to believe more than others. That to me would suggest that perhaps this pregnancy isn't developing in the way I would be expecting it to. You know, vaginal delivery can seem very easy. A cesarean section can seem very easy. The question is it right for you? Those principles that you set in stone in the first trimester continue to serve you well throughout the rest of the pregnancy and beyond.
Welcome to the Unii podcast with me, your host, Dr. Saranya. Today we're answering your pregnancy questions with Unii expert Dr. Shree Datta. She's an award-winning obstetrician and gynaecologist with over 2 decades of experience and founder of Her Healthcare, which offers private gynaecology and maternity services in London. Shree has hosted journeys on preconception and the 3 trimesters of pregnancy with us here at Unii. She has held a number of national positions in the UK, which include being a council member and trustee to the General Medical Council, where she underlined the importance of patient safety. She was elected, unopposed, to chair the UK British Medical Association's Junior Doctors Committee and subsequently the North European Junior Doctors Committee. She was subsequently awarded a fellowship of the British Medical Association and was highlighted as one of the top 50 UK BME pioneers by Hospital Services Journal. Her passion for excellence in care led her to being awarded the Excellence in Teaching Award by St George's Medical School in 2013, and she has been invited to set up teaching courses internationally. She has been published extensively, and her textbooks are used by medical students and junior doctors alike with 5-star reviews. We seek to reassure as well as inform on this podcast, and I look forward to addressing some of the pregnancy concerns we hear from listeners with you. Let's take a look in Unii's pregnancy journey.
Welcome to this exciting Unii journey on pregnancy. My passion lies in empowering individuals and couples to embark on their parenthood journey with confidence and knowledge. Pregnancy isn't just about carrying a child. It's about laying strong foundations for your baby's future well-being. Whether you've just learned that you're expecting or you are well into your second trimester, this journey is for you. We'll explore the critical elements of pregnancy care, from understanding your body's symptoms week by week to discussing parenting with your partner, knowing when to contact your healthcare provider, and making the right lifestyle choices.
Welcome, Shree. It's such a pleasure to have you today, and I'm delighted to meet you. And what an impressive set of achievements.
Thank you so much. Well, you know, my work is my passion. So it was a great experience through training to learn about the pregnancy journey myself, and now to be able to help others as a consultant obstetrician and gynaecologist. So thank you very much for having me.
So one thing I love is to hear about what inspires people to become the role that they've chosen. And I'd love to hear more about what made you pursue obstetrics and gynaecology, or obs and gynae, as we say.
Of course. Well, funnily enough, I'm going to take you on a journey back to Y2K. That's when I first came across obstetrics and gynaecology as a medical student, and I fell in love with it straight away. It's the only specialty in medicine where you've got 2 patients for the price of 1. And I just thought it was awesome. And I just have not looked back since then. And it's amazing in terms of the amount of variety of pathology that you get to see, the types of patients, and what can happen not just in pregnancy, but throughout the whole life course of a woman's reproductive life. And that's just what's kept me going. And there's so much to being a doctor, as you know, beyond just delivering individual patient care. There's the education of other doctors, patients, research. So it all culminates in being able to provide the best support for my patients and women in general. And that's really what inspires me to continue doing the work that I'm doing.
That's really interesting. 'Cause I think for me, it was the same at medical school. I just felt like paediatrics was the perfect fit. And again, not just treating one kind of patient. I've got my patients and their parents.
Yeah.
So again, kind of two different types.
Yes, you get 3 for the price of 1.
Yes, I do. And also, I'd like to hear about how your day-to-day differs from my own. So tell me about a typical day at work.
Well, firstly, I'm not sure there is a typical day at work. Right now, my rota varies from week to week. So sometimes I'm on a different hospital site in the afternoon to in the morning. But it could be something as simple as doing some operations in the morning on a Monday, cesarean sections or gynaecology operations, and then doing a clinic or being on call later on in the afternoon. So you're constantly seeing patients. And I think one person described it to me as, if you're doing an office job, the equivalent is having a meeting that you need to prepare for every 15 minutes when it comes to a clinic. So that's the intensity that you can have. But then other days can be really quiet, just depending on whether you're on call and how many patients are coming through, how many emergencies you're dealing with. But that's one of the things that I'm sure you'll agree we both like about the job. There is an unpredictability factor. So you're never going to get bored of the day job, as it were, from that perspective. And that's partly also what keeps you on your toes.
I was just going to say that exact phrase, that it's fantastic to be kept on your toes. And that's, yeah, you're absolutely right. That's what I love about my job too. And it sounds like there's so much variety. Yeah. It's very inspiring. Yeah. I think you've almost inspired me to consider obs and gynae.
That's good to know.
So here at Uni, we make a global podcast. And of course, you work in London, which is a major international city. We've got lots of viewers from all over the world. And I'm sure you know, as I do, that in certain cultures compared to others, there may be that, personal shame or embarrassment where people feel that they can't talk about their sexual health and issues down below. Have you got any specific advice for women who maybe feel that way or have that embarrassment or worry?
Well, it's really funny you should say that. We were just discussing this last night at a meeting. And I think the biggest factor for us is not just raising awareness of women's health problems, but making it normal to be able to talk about them in the public arena. We talk about high blood pressure, heart attacks. Why can't we talk about period problems? Why can't we talk about abnormal smears? There's still a stigma attached to that. And I think there's still a long way for us to go to make sure that every woman feels comfortable raising these issues in the same way as they raise other healthcare issues. So part of it is us and the way in which we talk about healthcare problems, as well as women then being able to discuss those problems in any setting. And I think that's going to take time and a change in culture. It is happening. We're seeing it with Davina McCall, who's done more for the menopause in a year than I could do probably in 10. And we need to see that happening with the rest of women's health. And I hope by doing podcasts like this, by speaking more and more within the general public, people do start to feel comfortable about what can be quite an intimate subject. Quite often what I'm ending up doing is speaking to people about the nature of their periods, how heavy their bleeding is, within 5 minutes of meeting them, which is not the easiest topic to talk about at the best of times. So you really have to make people feel comfortable very, very early on. And developing that rapport, being able to listen to them, is a key part of my everyday job.
And I think something key that you said there was early on, because obviously as doctors we know that earlier that something is brought to our attention, the less troublesome possibly the management can be. So it's really important that you've given that reassurance to your patients, because it makes everyone's job a little bit easier.
It does,
but
and
also safer.
Yes, and it makes the treatment far more easier as well. We've just gone through COVID, so there is a longer waiting time, and you can see that pathology growing and growing before your very eyes sometimes. So it is about encouraging people to present early, definitely.
So Shree, you've worked with us on our pregnancy journey, probably one of the most significant, and I know definitely very relevant for me. I have to say, something that I was surprised about talking to others is the frequency of scans. So I wasn't aware that apart from the 12-week and the 20-week scan being a low-risk pregnancy, I wouldn't have any more after that. And after 4 months, you don't get the chance to see your baby until you meet them in real life, which is obviously very exciting. And now I cannot wait for that moment. Are there any other common surprises that you hear from women in your clinics?
Gosh, the biggest factor that women discuss pretty early on is around what they can eat, actually. And that is a minefield. So there is a lot of guidance out there about what to avoid. The common questions are around caffeine, everyday drinks, actually, just as much as what people can actually eat. And I guess the other factor is later on in pregnancy, delivery. That has got to be the big one. And there are so many deliberations. And we've got checks and balances in place, such as antenatal classes, which help to a certain extent. But you never know until you've gone through it. And yet you've got 40 weeks building up to this one big moment of delivering your baby. So that by far has got to be one of the common areas that people come and discuss with me because of the uncertainty around it.
And I can definitely sympathise with that. I've spent a lot of time on Google looking up what I can and can't eat. So if I made you Minister of Health for the day, there's obviously so much information out there, but is there any one area that you feel could be better represented in terms of information and support in pregnancy?
I would have to say the warning signs of what to look out for, and also the reassurance that nothing is too small to come and see us for advice on. So one of the biggest factors is around baby movements and how often you're feeling baby movements. And, some people do leave it until later on in the evening, the next day. But if you're worried, like we were saying earlier, just give us a call. Any pregnant patient is given a booklet of their own information, but also ours within the hospital, and a list of numbers. Those numbers are available to dial 24 hours a day, 7 days a week. So really, if there is a problem, then you are able to tap in. And it's not about annoying or bothering anyone. It's about getting the support and reassurance that you need.
And that's a really important thing to stress, that you're never bothering anybody, and it's better to be safe.
Definitely, without a doubt. This is a very unique experience in anybody's life. So making sure that you know what's going on, we'd like to support you in that in any way we can.
So I'd like to tackle some of those frequently asked questions from our users at uni, especially when you first find out that you're pregnant. So something that caught a lot of media attention was when Meghan Markle found out she was pregnant at the age of 37, and it was referred to as a geriatric pregnancy. What is the need for that label, and what does it mean? What sort of age are you considered geriatric?
Okay, so actually the pillars are moving when we label someone as being a geriatric pregnancy, and I'll talk about why the term's important in a second. But effectively, it used to be 35, but as the average age of first pregnancy increases, increasingly we're referring to a geriatric pregnancy as someone who is over the age of 40 at the time of their first pregnancy. So if you're on your third pregnancy and you're 39 or 42, it doesn't make so much of a difference, all right? But in terms of why that term is important, well, actually, we know that as we get older, we are more susceptible to medical problems like diabetes, like high blood pressure. And what pregnancy does is it acts as a stress factor. So it draws out those medical problems far more easily So actually knowing that someone is slightly older at the start of pregnancy, and therefore the associated risks of medical problems, miscarriage, problems such as potentially Down syndrome, are all worth bearing in mind when you're seeing that woman and also speaking to her. Equally, at the other end of pregnancy, delivery. If someone's a little bit older, they may face induction because of those medical factors. They may need to think about a caesarean section sooner rather than later in labour. And so these are all the factors that I'm thinking about behind the scenes when someone's presenting and they're slightly older at the time of their first pregnancy.
Okay, so it's more of something that we need to be aware of to determine what might happen, and
Yes.
It's better for preparation.
Yes, absolutely. From both sides, from the patient side, but also from our side as well.
Okay, great. And what about dyeing your hair in pregnancy?
Yeah, so that's a really common question I get asked about, actually. And the vast majority of dyes, as long as they are not used too frequently in pregnancy, and if you look at the NHS guidance, are deemed absolutely safe. However, if you're not sure, it is about checking those ingredients and consulting your hairdresser. You may have to change the type of dye you're using or the frequency at which you're dyeing your hair. But nowadays, that's far less of an issue than it perhaps used to be.
Okay, that's helpful. So just seek advice, as with everything else, essentially.
Yes.
Let's talk about stretch marks. So is there any evidence-based way to prevent stretch marks?
In a nutshell, no. Okay, but there are ways in which you can manage stretch marks, okay? There is a genetic component to developing stretch marks, and there's also a hormonal component as well. Now, depending on how well moisturised your tummy is, how big this baby is growing, also then influences quite how many stretch marks you actually develop. And equally, the time at which you fall pregnant for your first pregnancy can have an impact on the stretchability of the skin. So there are some individual factors, and then there are some background factors that will influence them. What you can do on a day-to-day basis is simply make sure the area is well moisturised, because you cannot change the hormonal changes that are going on or the balance, and you can't change your genes. So it is about working within the frame that you've been given effectively.
So do what you can do.
Yeah, absolutely. And remember, some people are more prone to stretch marks than others, and that's you're going to have that individual variation. If you're really worried, go and consult a dermatologist. But again, the advice that they will be giving is certainly limited, unfortunately.
And something that I've been asked a lot is, do you know what you're having? And people have guessed whether I'm having a boy or a girl based on the shape of me and my bump. Is there any evidence behind the way you carry and the sex of the baby?
Oh my goodness, if I could tell you the number of old wives' tales there are from hanging a pendant and watching which way the pendant swings versus the size and shape of your bump. Unfortunately, there aren't any studies to support any of those old sayings at the moment, all right? And so really we are reliant on the scans that we're doing at a set time in your pregnancy, which is the second scan that you were referring to earlier. That's probably the most accurate way and time to be able to diagnose the sex of your baby. So other ways, we're still working on it.
Though everybody that guessed correctly. So someone out there is selling some information that's true. Is there any established safe amount of caffeine that you can have in pregnancy? I know we've touched on caffeine already.
Yeah, so generally the advice relates to the type of caffeine that you're having. And effectively, as a baseline, people say around a cup of coffee a day. That's it. But again, remember, if you've got strong filter coffee, then that would be a lower amount or a more dilute version than if you've got instant coffee, for example. And remember, caffeine isn't just in coffee and tea. You're getting it potentially in chocolate, Coke if you're drinking Coke. So there are other forms of caffeine that we need to think about. So we're talking about the overarching level. And certainly if you are addicted to coffee, then looking at decaffeinated versions is a good way of making sure you're getting that hit without getting the hit, as it were. And similarly, looking at teas, a lot of people don't appreciate green tea has got quite a lot of caffeine in it. So you may actually have to reassess and reevaluate the type of drink that you're having, be it herbals versus green or black tea.
And is there a rule about decaf?
Not so much, actually. It's quite interesting. The studies are far more limited. I think there is quite a low level, again, but there's no kind of limit on how many cups of decaf that people actually talk about. The less, the better, as with most of these things.
And what about wine?
So if you look at the college guidance, generally speaking, they say abstinence is best. However, the odd glass of wine in pregnancy hasn't been shown to be harmful. So that's the general advice that we've been working to.
And we've talked about drink. Let's talk about food. So are you really eating for two or not?
No, so that's a really common myth, and one which some people may want to believe more than others. But actually, on average, you need around about 200 extra calories, particularly in the first half of pregnancy. So that is maybe a snack, effectively, more than you're already eating. So it's about just eating healthily rather than looking at the amount that you're eating, and focusing in on nutritious and a balanced diet regularly rather than a hectic lifestyle where you're just grabbing convenience food. So I wouldn't just emphasize how much you're eating. I would try and look at the type of foods that you're taking in. And we mentioned food earlier. Of course, there are some easy no-goes, but even within the rest of that, look at your plate regularly to make sure it's giving you the nutrition you and your baby need.
And whilst you mentioned the easy no-goes, things that I often find myself looking up are sort of the cured meats like Parma ham and things like chorizo, as well as sushi. I've actually heard a lot of differing advice about that. What would you normally suggest?
I would say anything cooked is great. That's a bottom line. So there are so many different types of meats that are available. I would try and avoid any kind of processed meat or raw fish. So those are two areas that very clearly I would steer clear of for the 9 months of pregnancy, I'm afraid. So, yeah.
That's a helpful way to kind of make it black or white.
Yeah.
And a lot of wellness experts and some celebrities talk about avoiding electromagnetic fields and radiation from phones. Is there any evidence base to that?
So there isn't so much on phones and electromagnetic fields. And if you think about it, you mentioned the scans, we're using ultrasound scans through pregnancy. And in some cases, we do look at chest x-rays, we do think about MRIs, but only where necessary. So of course, I wouldn't keep your phone too close to your tummy all the time. I wouldn't use your phone more than you need to. But part of that also relates to your day-to-day habit. So, for example, I would recommend anyone, pregnant or non-pregnant, avoid looking at their phone in the last hour of the day before going to bed. So there are so many different reasons to look at what you're doing and potentially to use pregnancy as a springboard to change the way in which you're eating, what you're eating, when you're eating, and some of your daily habits. It's a great opportunity just to reevaluate your health, actually, moving forward.
Thank you. That's really helpful. And I'm sure our listeners will also appreciate your advice on some of those common myths and, burning questions. So if we go back to the beginning, something which can be quite exciting, but also can cause a bit of worry are pregnancy tests. There are so many out there. And I just wondered, from your perspective, how do you advise people to choose the right pregnancy test? How much should they be spending and how many should we be doing?
Well, I think the first thing to think about is the timing of doing pregnancy tests, and that relates to your menstrual cycle, whether that's regular or not. Because you could do the best pregnancy test in the world, but if it's too early, it's too early, all right? So generally speaking, urine pregnancy tests are sensitive enough to detect pregnancy from 3 weeks onwards at the earliest, okay? So that would be the first thing. And then going to a reputable shop, which has a reputation for selling products of good quality, would be my mainstay. I don't endorse any specific brands or companies, but really looking at something called the sensitivity and the specificity of those urine tests is particularly important. So read the label. Don't just go onto Amazon and get the first thing you can find. And actually, pregnancy tests aren't or shouldn't be so expensive. You should be able to choose from a range of different options, as we do for anything, on the supermarket shelves or the pharmacy shelves, and have the reassurance that it is a good enough standard test. Now, if you're not sure about the answer, because actually pregnancy tests do require interpretation, then you can always repeat the tests. And it just depends on the type of test that you buy. You could buy a single-use test, or you can buy a multi-box of different sticks that you can dip the urine in. Make sure that you're dipping enough urine, and the right type of urine could be the first catch, for example, once you've woken up in the morning, and leave it for the right amount of time. And if you're not sure if you're interpreting it correctly, there are some YouTube videos out there which can be quite useful. And again, if you're not sure if the answer's correct, simply repeat the test. That's the best way of doing things. On occasion, we as doctors do request blood tests where we're really not sure what's going on. And you've got to remember that pregnancy tests are not necessarily just specific for pregnancy. So even if someone's not pregnant, the hormones that are detected can still be raised for other causes. So that's one caveat that you need to be aware of.
So contraception is something you speak about to women on a daily basis. Is there any one form that you recommend as being superior over the others?
Do you know, that's a really interesting question, because I think it really varies according to the individual's background, their circumstances, what they're comfortable with. And that's something we explore together in our consultations based on an examination or any investigations. And also it depends on whether they've got any other gynecological problems. So for example, if someone's got an irregular or heavy menstrual cycle, then they may actually be better suited to a certain type of coil, the Mirena coil, or the pill, versus patches or implants, which can exacerbate some of the other symptoms that they may have. So that's something that we would consider in terms of what the woman is looking for in their contraception, what they feel comfortable with, and actually medically what suits their clinical background.
And is there any form so fail-safe that you really can't be pregnant if you miss a period? It is probably something else.
So in fact, if you look at the statistics, a vasectomy is 100 times more effective than female sterilisation. So that certainly is food for thought. And that would be the one factor that would make me think, let me go back to the pregnancy test rather than the contraceptive failing. However, if the pregnancy test is repeatedly positive, I would then go back to thinking maybe the vasectomy or the sterilisation hasn't on this occasion worked.
That's interesting. I didn't think about that. And when you do find out you're pregnant, obviously it can be an exciting time, but one thing people worry about is, when should I share that news with others? How do you advise women on that?
So again, this is a really common question, and it's really individual. It depends on how comfortable you are telling your family, how confident you feel. So for example, if someone's gone through 2 or 3 miscarriages, they may want the security of the first, even maybe second scan, which takes you up to 20 weeks before they start sharing the news. But effectively, you have the choice of sharing it whenever you feel happy and confident with your own pregnancy. And that can vary from the first scan at 12 weeks when everything's been seen and initially checked over versus the second scan, or even later on. The one thing I would say is that if you're an employee, by about 20 weeks would be about the stage to start thinking about telling your employer so they can make plans. You can start thinking about maternity leave. And also it's around about the 20 weeks that you are eligible for the famous MAT B certificate in the NHS, which then means that you are exempt from paying prescriptions, for example. So there's a practical side to that advice as well.
That's a really helpful way to think about it. I hadn't considered even the employer in when you're thinking who to tell. I was just thinking about family and friends.
Of course. But that's an important part of your life as well.
So obviously living in London, I have the added benefit of being able to access your services if I wanted to. But for anybody that's looking for an obstetrician or a gynaecologist who maybe doesn't have that easy access, how would you advise people to choose a specialist?
Well, again, it depends on their needs. And actually, I think it goes beyond choosing a specialist in obstetrics and gynaecology. I think for any patient who's looking for care, you have to have that rapport with your doctor. You're going to talk about something that's really intimate. That could be, something really simple with your GP or something really complicated with a specialist. So I would say choose someone who you're comfortable with, who you can be open with, and who you trust in terms of their expertise and depth of knowledge. Patients do travel up and down the country, both in the NHS, because they're referred by their local doctors to a specialist centre, but also in the private sector. People do jet set. We know of international travel, tourism, health tourism, to find the expertise they need. And really it's up to you where you feel comfortable enough with gaining that information. And that could be, luckily, very local, or it might be that you need to travel, depending on the expertise that you need to tap into.
I think, as you say, trust is incredibly important.
Yeah, and that's quite difficult to put your finger on. You don't get tick box trust. Yeah, I'll choose them. That's something that you need to test out. It could be a telephone call, and finding out what their reviews have been, what they're renowned for in terms of their approach. And actually, it depends on what you need. If you need a good surgeon, you might not want someone who is really chatty. You might just be happy with someone who can do a really good job. But sometimes you need someone who can communicate more than do a good operation. So again, it depends on what you need and when. And again, don't be afraid to chop and change. It's what you need at that certain point.
I think that's important as well to highlight that you're not committed to one person. There are options out there, and you find what works for you.
Yes, and often you'll find doctors are the same. Will say, I'm really good at this, but I'm not so good at this, so I'm going to advise that you go and see a subspecialist in this area. And that's the reason we're doing it.
Yeah. So as exciting as it is to find out you're in that first trimester, it comes with a whole host of other not so wonderful symptoms, including nausea and vomiting, the morning sickness. Now, in pregnancy, we're advised to take supplements and those prenatal vitamins, but is there a problem with absorbing those at times if you're having severe morning sickness?
Of course. I think the first thing to say is when it comes to taking supplements, we actually recommend women start taking supplements 3 months before pregnancy if you are planning on conceiving. All right, that's the first thing to say. Then I would, with any type of supplement, look at when you're taking the supplement and how you should be taking the supplement to make sure you are maximally absorbing it. And that's something I think is underrated. If you are taking a supplement with a hot drink, for example, that can slow down its absorption. If you're taking a supplement separate to food, that can affect absorption as well. So making sure you're taking the right supplement in the right way should not be underestimated. Now, then if you're adding in pregnancy symptoms of morning sickness, then of course that's going to make anything difficult to absorb, and that needs to be taken into consideration. There you may need to look at the timing at which you take supplements. Morning sickness, by its very name, tends to be more pronounced at the beginning of the day. So you may have to move those supplements to later on in the afternoon and evening. But equally, I would argue managing your symptoms of morning sickness early on, as we spoke about, is just as important. So it's a two-way approach. It is looking at the supplements and how best to take the supplements, as well as managing the impact of early pregnancy and sickness, and making sure it doesn't snowball over the period of 2, 3, 4 weeks.
Wow, I hadn't even thought about what liquids to take your prenatal vitamins with.
I know.
That's an important consideration.
Yeah.
And whilst we're talking about those vitamins, there's obviously a lot of choice out there, but are there any particular ingredients in those supplements that maybe are not advisable that we should be aware of?
That's a really interesting question, and in fact we were just discussing this earlier this morning at another lecture I was doing. It's really important to look at what your body needs, and that's not always easy. So, for example, vitamin D. We know that most people run at a deficiency of vitamin D. So adding that in to a multivitamin supplement, no problems. But if you then add in extra supplements, be it iron or other different vitamins, then that is actually worth just taking a moment before you actually supplement, if you don't know what your initial levels are. And certainly there are some minerals or irons that we think about before prescribing more and more of. So, for example, potassium, magnesium, those are things that I'd like to know the baseline of before adding those in.
So would you encourage anyone that's thinking about getting pregnant to get a set of routine blood tests, for example, just to check those things beforehand?
You can do. You don't necessarily need to, but if you're really digging into the detail of supplements, it's ideal to know what you actually need. And some of that's very easy to do, and some of it's very easy to supplement. Now, in a multivitamin, you're going to get some of those supplements automatically, whether you need it or not, but the absorption of that can vary, and there's some evidence to suggest it's actually better to take an individual supplement for an individual vitamin. However, there's only so many vitamins you can take in a day. So multivitamin can streamline things more than anything, especially if you've got morning sickness, for example.
Yeah, it just makes things a bit easier.
Absolutely.
So you mentioned in your journeys about weight gain being a bit more rapid in the second and third trimesters. But what about weight gain in the first trimester? What should women expect?
So actually, you may not gain any weight, particularly if you're suffering from morning sickness, you might actually lose weight. So there again, it's about maintaining regular nutrition rather than looking at the size of your jeans and your waistline. But gradually, as the pregnancy grows, you are naturally going to have to change the clothes you wear into something that's far more comfortable and suitable, not just for weight gain. So as long as you have the energy levels that you need, you're eating regularly and eating well, as we said, that's what we'd actually focus on more, rather than, gosh, you've gained 4 pounds this week, that is too much, or 2 pounds in the pregnancy, because at that time, that may be exactly what you need. And you may find that actually, in the first half of pregnancy, you don't put on very much weight, you don't show. That's entirely normal.
So it's not necessarily about a specific quantity in the first trimester.
No. And again, that is going to vary depending on your ethnicity, your own background, any medical disorders that you suffer from as well. Little ladies can have little babies, we know that. But again, it's keeping the whole picture in perspective.
One of the biggest concerns in that first trimester is the risk of miscarriage. How do you assess for that risk?
Of course. So again, it comes back to speaking to the couple about any symptoms, any background they have, which would put them at a higher risk of miscarriage, which would include maternal age, for example, but also any symptoms they've come to see me about. So the symptoms specifically I'd be looking out for are any bleeding, any significant tummy pains. Quite natural to get some cramps or growing pains throughout pregnancy, but how significant is that pain? And those are the types of things I would be digging into. Now, we've also mentioned pregnancy symptoms, the breast tenderness, breast swelling, bloating, morning sickness. And again, although they are a nuisance, they tell me that your hormones are working. This pregnancy is still there. And so again, if all of a sudden, over the last couple of days, those have gradually disappeared, that to me would suggest that perhaps this pregnancy isn't developing in the way I would be expecting it to. So there are various nuances and various very obvious symptoms that I would be looking for.
And that's interesting. It's not just the presence, it's also the absence of symptoms.
Yes.
So you mentioned about bleeding and cramping. Do those things always mean miscarriage?
No, not always. So again, that's where the assessment is really important. And here we may not just consider examination, because there are other causes of bleeding, there are other causes of pain that may not necessarily be related to your pregnancy. And so by examining, by requesting blood tests, or doing an extra ultrasound can be really helpful just to give you that peace of mind. And there are women who will have regular breakthrough bleeds throughout the first trimester, second trimester of pregnancy. And that can be a really stressful thing. And that's where actually going to your hospital, seeking the support, seeking regular scans is something that we're able to provide very easily. And that's why we do so.
Okay, so something to know about, but also to seek help.
Absolutely.
With. And talking about miscarriages, if you've had one miscarriage already, are you likely to have another?
Yes, so absolutely. That's one of the things that we would think about when we're meeting you, your partner, and we're thinking about how this pregnancy is likely to progress. And in some cases, in fact, when someone has had a miscarriage, we say to them, in your next pregnancy, please come and let us know early that you are pregnant. We will organise a reassurance scan at 6 weeks. We will consider additional supplement medication as a prescription, not over the counter, to help you maintain a healthy pregnancy. So increasingly, there are supportive additional measures that we can put in place to ensure it doesn't happen again. However, an abnormal pregnancy is an abnormal pregnancy. We cannot stop a miscarriage from happening. We can simply give you the best chance possible for that pregnancy to progress.
And what do you advise couples who ask when they can start trying again?
So if you look at the evidence, it's quite variable actually. Depending on the experience they've gone through, it could be as quick as after their next period. And I generally say you need to be mentally as well as physically ready to take on another pregnancy and the uncertainty that it could bring, because it can be quite traumatic depending on the stage at which you've gone through a miscarriage, your own background, the number of times you've gone through a miscarriage, and the stress around you. That's even before you consider getting married, moving house, all the additional social and work stresses that we face in everyday life. So that to me is quite an individual decision. Having said that, I would be looking at the medical background, what they've just gone through, how fit and well they are, their age, their circumstances, before saying, actually, in your case, have 1 or 2 regular periods before trying, or just try after a normal period. And it can take time for those periods to normalise after a miscarriage.
And that's really helpful to know. And I'm sure you've delivered lots of rainbow babies, and I'm sure lots of our listeners will be happy to hear that too.
Absolutely. So just to reassure people, miscarriage is incredibly common, but it's not so much talked about, unfortunately, because it's one of those things that's hidden away. It's a sad part of our lives. So people don't like to bring it up in everyday conversation, quite rightly. But on average, 1 in 4 couples go through a miscarriage. So that's 25% of the population. And most of those go on to then have a happy, healthy, full-term pregnancy. But you may need more support in the next pregnancy. And again, coming to us early, once you are pregnant, will help us to provide that to you early on.
So in your journey, you talk about how those symptoms of the first trimester tend to subside and women report that they have more energy. You've got the excitement of that 20-week scan also. How do you tend to advise your patients entering into this trimester?
Well, I think really it's about the same process that they've started to follow from the first trimester, and that is just to take things day by day, week by week, and to monitor their everyday activities, their diet, the lifestyle and any symptoms that they're getting. So just as you enter the second trimester doesn't mean that your symptoms are going to stop overnight, but they may start to subside, although in a small group of women, they actually do carry on, maybe less severe throughout the second trimester. So again, that picture really is very variable from person to person, and it's about responding to that. So for example, if someone continues to vomit, and looking at whether they need medication throughout the second trimester, or if someone develops new symptoms, signs of infection, for example, then addressing that. So you can have different challenges in the second trimester, or you can sail through it. It's anybody's guess. But again, making sure that you touch base with us with that second trimester scan at 20 weeks is probably an apt time. And there are certain checkpoints at which, in the NHS particularly, you'll be able to see your midwife. And that's a good opportunity just to make sure you're feeling your way through your pregnancy and things are going in the direction that we anticipate.
And I think that's really useful what you said about taking things day by day, because things do really change from day to day.
Yes.
So I'm sure many of your patients do contact you at their own pace, but is there anything particular in terms of seeking medical help that you want your patients to know about in this trimester?
So I guess it just depends on the types of symptoms that they are taking over from the first trimester and any affiliated medical disorders. So, for example, if they suffer from, Crohn's disease or diabetes early on, they may have had diabetes even before getting pregnant, we would touch base with them regularly throughout the pregnancy. Same with thyroid disorders, asthma, etc. So again, the medical problems may influence how frequently we see someone. And then, of course, the results of the 20-week scan, if it's a high-risk pregnancy, such as a twin pregnancy, we would tend to touch base with the patients more often. Now, I spoke about concerning symptoms in the first trimester, and that carries through to the second trimester as well, specifically around fresh bleeding or tummy pains that just won't go away with paracetamol, for example. And then as you enter the second trimester from 20 weeks onwards, you're going to start to feel baby move. And actually being able to feel baby move and monitor those is equally important. So you can start to get a new set of challenges as you progress through pregnancy, and it's about knowing what those are and how to respond, when to respond to them.
So I suppose it's about kind of identifying what's somewhat normal for you, and if something doesn't feel right, that's when you should be seeking medical help.
Exactly. That is perfectly put in a nutshell.
And are there any specific do's and don'ts in the second trimester?
I think actually the biggest take-home message in the second trimester is just to continue what you're doing. Pregnancy is not seen as a disease, it is a natural state of being. So we'd like you to be able to continue your activities of daily living. Fair enough, you're not going to be running a marathon particularly, but you still can undertake your activities of daily living, go to work. You may need some adjustments, but again, that depends on your specific circumstances. The biggest point to me is to make sure that you're maintaining a healthy and balanced lifestyle. You're eating at the right time, and again, you're eating the right things. So those principles that you set in stone in the first trimester continue to serve you well throughout the rest of the pregnancy and beyond, in fact.
And you touched on physical activity. What about things like lifting heavy objects? What's the advice on that?
Sure. Again, so this depends on what you mean by lifting heavy objects. I mean, you can certainly go shopping, but when it comes to weightlifting, then it depends how frequently, what weights you're using, what exercises you're doing. So those type of specialist areas would actually need to break down with you individually to see what you can continue doing and what you can't. And same with the different types of exercises. We certainly encourage activity in pregnancy, but you may have to modify the types of exercise, the types of yoga that you're doing.
And which kinds of exercises are, say, advisable?
The most basic one is to continue walking, all right? And of course, you may need to start taking regular breaks when you're walking, but that's absolutely fine. Just go as far as you can do. The more strenuous types of exercise, HIIT classes, for example, are probably the types of exercises that we would stay away from. So again, just thinking about what suits you and how high impact the exercise regime that you do is important to just potentially reconsider as you become more advanced in pregnancy.
I've heard that if you can still say a sentence whilst you're doing the activity, then it's okay. Is that right?
That's a really interesting one. I think that probably stands even if you're not pregnant, actually, as opposed to if you are. And again, it depends on the intensity of the exercise. What you may find is that you're doing less intense exercise, but getting to that same level of breathlessness that perhaps you would get to further down your exercise regime. So notice the impact of what you're doing. Don't expect to be hitting the same exercise milestones that you were hitting before you were pregnant, or indeed in the first trimester, and be comfortable with that. Go with the flow, as it were.
And something that we've touched on in the first trimester was about weight gain. Now, in the second trimester, what kind of weight gain should we be expecting?
So overall in pregnancy, towards the end, you're looking at about 10 or 12 kilos in total, all right? So now when you start putting that weight on, and how quickly can vary from person to person, but obviously if you're starting to put on a kilo or two every week from 20 weeks, then that is going to exceed the 10 to 12 kilos. So it's about being mindful and noticing whether your appetite has gone up, whether you're just doing less activity, you're not feeling so hungry, whether you're able to eat, and putting all of those factors into perspective when it comes to looking at how your baby's developing. And remember, you're touching base through antenatal appointments to make sure that your baby is growing in the right direction and by the right amount.
And how do you support women that worry about that degree of weight gain?
So again, that it may involve them being referred to a dietitian or a counsellor, or having specialist midwifery input, seeing where that anxiety comes from. Is there a background of eating disorders, a background of medical disorders that can impact what they're doing, how their appetite is, and seeing how best we can support that individual. Part of it may actually be psychological as opposed to the physical dietary requirements that they need in their pregnancy.
Okay, that's really helpful. So it's kind of a person-tailored approach, which is
absolutely
really nice.
Yeah.
Thank you, that's really helpful. So it's about being taking a person-specific approach rather than a one-size-fits-all.
Absolutely, yeah.
And that's really reassuring to know.
Good.
So obviously we've talked about stretch marks and the kind of lotions that you might want to use and moisturising. Are there any beauty products that we should be aware of in pregnancy that may not be safe?
That's a really interesting question. And I think in pregnancy, you want to minimise the exposure that you have to any kind of artificial ingredients in products, be it through your diet or the products that you're using. And we certainly talked about hair dyes, and I would expand that to the types of products that you're using in body lotions, in your makeup. And I would look at going as natural as possible. And if you are wearing makeup, looking at the types of ingredients that there are. So it's not necessarily about avoiding specific ingredients per se, but looking at the genetic makeup of the products that you're using and whether you actually need to continue using them. Your skin changes in pregnancy, we know that. And it's about thinking about what you're comfortable with versus what you need to wear, be it for skin disorders like eczema, and seeking the specialist advice if you need it. So, yeah.
I guess on the topic of that, something that's become much more popular is, skincare, things like hyaluronic acid and retinol. How about those?
So retinol is probably something that I would stay away from in pregnancy in terms of skin products. But generally speaking, beyond that, it is something that is worth considering on an individual basis. And there's nothing strongly that we would need to think about avoiding.
That's really useful because actually it's becoming much more popular. You're seeing those products around, and it's useful for people to know what they should be looking out for. So we talked about the 20-week scan already, that anatomy or anomaly scan, which it's called. It can be a really exciting time, and I know personally it was lovely to see all those different body parts of my baby at the 20-week scan. Do you have any fond memories or a particular story of the 20-week scan that you can share with us?
Gosh, I think the most common one that comes to mind is when you actually see the baby and the baby's hand, and you can see it almost waving. That's always lovely. And I think the other fun one is when they're doing hiccups, they almost look as though the whole baby is just bouncing up regularly. So those are probably the nicest memories that you can give parents at the time. But I think just a reassurance of seeing baby's heartbeat. And also going back to the first 12-week scan, diagnosing twins is always exciting when people aren't expecting twins. So that can be interesting to do as well.
Oh, I can imagine. Have you had any really interesting reactions to that?
Shock, definitely. Father fainting more than anything else. Those are probably the ones that, again, I kind of think of. But most of the time, it's just a pleasant surprise. And the same when you're actually unveiling the sex as well. So it's so lovely to see couples kind of get really excited over what sex they're actually having.
Yeah, I know we definitely did.
Yeah.
So something that happens during this trimester is the oral glucose tolerance test. Can you just explain for our listeners what that involves and what they're likely to expect with it?
Absolutely. So this generally happens around about 28 weeks. And at the moment, we advise women who are at high risk of developing diabetes from a family history or a previous background complication to have that test done. And it can relate to your ethnicity, your body weight as well. And effectively, what it is a 2-hour test where you come in fasting and we test your blood glucose. We give you a sugary drink. I think it's about 75 to 100 mils worth of really sugar. And then over the space of 2 hours, we're monitoring your blood glucose. And you get the results back pretty quickly. And that's where we'll be able to diagnose whether you've got gestational diabetes, so diabetes in pregnancy, or actually your blood glucose level is normal. And then based on that, we will stratify whether you need a little bit more TLC in the pregnancy with more midwifery appointments, blood sugar monitoring, and obstetrician appointments with ultrasounds versus remaining a low-risk pregnancy where you simply see your midwife. So it is a really important milestone. And actually the timing is also really important because the accuracy of that test relates to 28 weeks. And in fact, and this is something we were speaking about earlier, you can't do it beyond a certain gestation. So in my mind, that would be quite a key point in the pregnancy to make sure if you need the test, you're getting it done, you're booked in on time.
And you mentioned about receiving extra TLC through the pregnancy if you do find you have gestational diabetes. Why is it that you might need more support?
So diabetes, as we know, is a medical complication and it has an impact on pregnancy and the delivery, all right? So it can impact not just on your own blood sugars, but the growth of your baby and subsequently the blood sugars of baby and the weight of baby and in the future baby's growth and development as a child. So it's got quite far-reaching consequences. So if we can monitor and manage that blood glucose level throughout the rest of the pregnancy, then potentially that may have an impact not just on the growth of your baby, the type of delivery you're having, and the health of your child later on beyond pregnancy. So there's so many reasons to try and manage that blood glucose level effectively, be it through diet or insulin injections, depending on how well we're able to manage it.
So as is probably quite obvious now, I'm in my 3rd trimester of the pregnancy, and something I'm definitely becoming more aware of is those fetal movements, so the movement of my baby. It can be quite difficult to know what is normal for you, and I feel the guidance when you read online can be very ambiguous. How do you advise people to monitor their fetal movements?
So you may notice that there's a difference in pattern from day to day. Some babies are very active at night, and some babies are active throughout the day. There's no normal per se. What we used to say on average is about 10 movements a day, but you might find that 7 of those come in an hour, and then you've got a very sleepy baby. So it's about knowing what over time has become normal for you and what to expect. And from 20 weeks, you start to feel initial flutters, but you will gradually start to recognise any patterns within your baby. And that's more relevant at an individual level than counting exactly 10 movements a day, because if someone's actually counting 15 or 20 and then suddenly they only count 10, well, that could seem problematic, but actually it's still meeting the minimum criteria of 10. So it's about knowing what's right for you. And if there is a significant change and it's causing you concern, just pick up that phone, as I said earlier, and give us a call. We will monitor baby. We'll ask you to come into hospital, but we'll monitor baby. And that reassurance of hearing your baby's heartbeat will just make your concerns evaporate. And we can do that very easily.
And I can completely empathise with that. I had an exact episode of that last week where I just had a gut feeling that something was different in terms of the movement. I picked up the phone, I spoke to a midwife, and they immediately said, come in. I was monitored and reassured. And actually, as you say, hearing that heartbeat, and then typically the baby started moving lots as soon as I got to the hospital, just gave me that reassurance. But it was just really nice to know that there was somebody at the end of the phone who was looking out for me, and it was so easy to access.
Yeah, and that's what we try and do for everyone and anyone who needs it throughout their stages of pregnancy.
And you mentioned about people feeling movements, especially at night time. That's definitely something I've noticed, especially when I get up to go to the toilet and then get back into bed. The baby is rolling all over the place. I just wonder, is the pattern that you notice in those last few weeks before your delivery predictive of your baby's sort of sleep-wake cycle?
I would love
once
it
they're
to
born.
be. But unfortunately, no, it's not necessarily a reflection of the type of baby that, and the routine or lack of, that you'll be experiencing once baby is born. The most important thing once baby is born is to work out a routine for you both that works for you, and that will take time. Babies react very differently to routines, to food, times, to senses, and it's very difficult to know what will work. That's kind of hit and miss in terms of feeling your way.
That's good to know, because otherwise I've got a very nocturnal baby and I'm heading for lots of sleepless nights, although that may happen anyway. So let's talk about due dates. Now, I'm approaching 35 weeks and I'm aware that most women deliver between 37 and 41. And of course, that's quite close for me. How accurate are those due dates?
So I would actually go back to something we spoke about at the very beginning, and that is your menstrual cycle. One thing you need to be aware of is we are very reliant on those due dates being calculated from a regular 28-day menstrual cycle. So if actually you have an irregular cycle, or your cycle isn't 4 weeks, it happens every 5 weeks, and actually your due date changes. If you've got a background history of polycystic ovary syndrome and you have irregular periods, it changes. That's why the 12-week ultrasound is actually particularly important, okay? And the due date is really important because it's what you hang everything on. You need to know. The first question people will say when you tell them you're pregnant is, when's it due? So it's so important socially, actually, and to plan things around. But actually, only 1 in 20 babies is born on his or her due date. So the chances are it's going to be born before or after. But it still gives us something to aim towards. The other factor to bear in mind is that 12-week scan. And one of the reasons we do it at 12 weeks is because it is the most accurate time to date your pregnancy. More so, in fact, than the dates that we get through your last menstrual period. So if there's a significant discrepancy, you'll find it's not that doctors don't believe you, but the scan tends to be on average more accurate than going by your period dates alone. And so that's why we do that, just to clarify to everyone.
I had no idea that was even part of the decision. So moving into the third trimester, there are a lot of physical changes that are happening and everything's suddenly moving quite quickly. One of the things that I'm sure many women, including myself, worries about is going into premature labour. How do you advise them on the signs of this?
Well, there are specific signs that would signify whether you're going into early labour, and those include regular contractions coming before 37 weeks, your mucus plug going, so a significant amount of discharge, breaking your waters, bleeding. Those are the types of symptoms that if you told me about on the phone, I'd be saying, I would like to see you in hospital, please. Let's just double check things. And those are the key factors that are the signs of labour potentially coming along sooner rather than later. Not always, but it is a potential sign. And with these things, why take the risk? Just come into hospital, we'll check things over. You may need to stay in overnight just so we can provide you the support you need in case problems develop. But if they don't, then you could be going home shortly.
And I know there are lots of things that people suggest to help bring on labour, but are there things out of our control, like stress, for example, that can do that?
Absolutely. So if you've had a massive shock all of a sudden, or of course if you had a traumatic accident, we know that can trigger early labour. And there are certain other things, so for example infection, I have seen then irritate the womb and lead to premature labour. Could be something as simple as gastroenteritis, believe it or not.
And whilst we're talking about stress, something that goes with that is anxiety. Pregnancy can be quite anxiety provoking. How do you support women with perinatal anxiety?
Well, again, it's about knowing what their concerns are and really responding to them from a very early stage. So if it is flagged up early in pregnancy, it is about looking at the areas of concern. Is it around labour? Is it around delivery? Is it because something has happened previously? And making sure that we have additional checkpoints for them. It may be that all they need is a reassuring conversation from a midwife. It may be that they actually need counselling. Maybe that they actually need support after delivery of baby as opposed to just before. And those are all things that we would formulate, not just as obstetricians, but with input from their midwife and potentially from counsellors, psychologists, psychiatrists even, depending on what the main issue is.
And I guess one of the things that I know I'm certainly concerned about is the delivery, and many women have a fear of delivery or tocophobia. How do you support those women?
So I think, again, conversations around labour can happen as early as the first trimester, especially if they've had a traumatic previous delivery. It's on their mind even in some cases before they've got pregnant. They need to go through that again, all right? So there it is about making sure that they've got the options available to them. And, vaginal delivery can seem very easy. A caesarean section can seem very easy. But the question is it right for you? There are risks to both, and you can never guarantee that someone will be successful at having a vaginal delivery. So those conversations are about finding out what risks the woman is happy to take and comfortable taking versus the benefit. And in some cases, when it comes to tocophobia, having gone to antenatal classes, read the information, spoken to midwives, women may be more comfortable thinking about a scheduled, planned caesarean section versus the unknown of labour. I've certainly come across that, but equally vice versa. You may find that someone prefers that to coming across an operation, and their main concern may actually be, what if I do need an emergency caesarean section? So again, it's about responding to the individual's concern and working out over time, may not be just one appointment, what is right for them.
And I suppose this is a good time to bring up the birth plan, or as we've discussed in my antenatal classes calling it a birth guide, because it doesn't necessarily mean it's something you have to follow, but it's there in case, and you've thought about all of the options and you're ready for them.
Exactly. And I think that's the most important role of the birth plan, actually. The fact that you've gone through every section, you know the different options, eventualities, and you also know that you may have to chop and change. You know, as with anything in life, you know, you're not going to go necessarily from A to B to C to D. It may be that you skip B, you go to C, or you may not need C at all. So it's about responding to the situation at the time, but being fully informed about what those choices are and what they mean for you at that time.
Yeah, I think that's important to stress, that it's a good opportunity to familiarise yourself with all of those options and also familiarise yourself with how you feel about them.
Absolutely.
So something I'm thinking about when we're talking about this birth guide is hypnobirthing. Now, I've read that it's becoming more and more popular. There's definitely more information out there on it than when I started as a doctor. And I've read that you need to be practicing those hypnobirthing methods from about 6 to 8 weeks before the delivery. Is that correct? And have you seen a lot of success in this method?
So that's really interesting, because actually if you look at the NICE guidelines, it hasn't quite made it to be a key recommendation. We do recommend things like doulas, having friends and family, obviously pain relief later on. But when it comes to hypnobirthing, at the moment, the evidence hasn't got to the stage where it's made it to the national guidance, which therefore means it's very difficult to predict or to in stone set a time at which you need to start these things. I think it's an individual decision in these types of cases where we don't have that evidence, because not having evidence doesn't mean it doesn't work. Could work, we just haven't done the right studies as yet. So it's not something that I would just rule out completely, but I would seek guidance from the specialists in hypnobirthing. And if they are saying start in the 3rd trimester early on, then it's worth considering. Equally though, I'd like to know what the risks are of hypnobirthing and the success for that individual case before relying on it and recommending it.
So it's about having all the information.
Always.
Yeah. So in pregnancy, there are quite a few medications that we may need to take, but in addition to that, there are some vaccinations that are offered, including the whooping cough vaccine. Now, this might be something that people have heard about, but don't maybe know a lot about. Can you tell us a bit about that vaccine?
So there are some vaccines in pregnancy that we would completely avoid, and those are live vaccines. But the couple that we do focus in on, and I do actually ask my patients when I see them, are the whooping cough, are the flu vaccinations, and also potentially where they are in their COVID regime. And that's because these are infections that can significantly affect your well-being at any stage of pregnancy. So although there are only set times at which you can take these vaccines, it is important to consider whether you are happy to take them, because of the potential impact, if you don't take them, that it could have in terms of your own well-being if you were to come across that as an infection. So that's a rationale behind having certain vaccinations that are allowed in pregnancy. However, having said that, you've got to remember that some people may have had the flu vaccine and reacted really badly to it. They may not want to. And the same with the whooping cough vaccine. They may just say, do you know what? Thanks, but no thanks. And equally, you have to respect that as long as they understand the potential exposure and the risks of infection in pregnancy, which are slightly more than if you're not pregnant and growing a baby effectively.
So this is a trimester that comes with lots of challenges, at times the aches and pains, and I know for me personally the swelling, especially when I'm up on my feet for a lot of the day. Have you got any natural ways to help with those?
Well, the first thing to consider is your hydration, all right? And I know it seems counterintuitive to drink more when you've got lots and lots of fluid accumulating in your legs. But pregnancy swelling is incredibly common, particularly in the third trimester. Having said that, it can be one of the signs of preeclampsia, which is a blood pressure related disorder. So that would be also at the back of my mind. And that's something that I potentially would like to exclude, depending on how bad the swelling is, if it's in both legs, how extensive it is. In terms of prevention, again, looking at your diet, making sure that you're having enough protein, and also your daily activities, how much standing you're doing. And if you can actually sit up with your legs elevated or sleep, which is quite difficult anyway in the third trimester, but sleep with your legs elevated, significantly elevated, not just slightly, but significantly elevated, that can have an impact. You may also benefit from wearing stockings, although they are quite restrictive. So that may be something you may want to try out or wear at certain set points of the day when you're standing.
That's useful to know about hydration. I didn't know that. And when we're talking about swelling, I know, of course, I'm wearing them today, but I do wonder about wearing heels. Is that okay in pregnancy?
Well, it depends on the type of heel that you're wearing. Probably wouldn't advise very, very narrow, high-heeled stilettos, for example, just because your centre of gravity changes with pregnancy. So your stability also changes. And something that we don't want is for you to fall or faint onto your tummy and then have further problems. So it's more around the practical side of things and the potential impact it can have on your lower back than anything further.
Okay, so again about being safe.
Yes.
And we've touched on physical activity in the second trimester, but now that we're in the third trimester, I know personally it's quite easy to come home and just want to put your feet up or curl up in a ball so that you don't have to do anything strenuous. But how would you advise physical activity as tailored in this pregnancy, in this trimester?
Well, again, actually, I think one of the key factors is to identify what you mean by physical activity, because remember, hoovering, technically light housework, is still physical activity. And you may find just by doing the housework, you are pooped in the third trimester, as opposed to going through the housework, going for a yoga session, going for a swim. So again, it's about feeling your way. One thing, if you are looking for additional activity to do that you cannot go wrong with, is walking. And you may find that you have to stop regularly, but those walks are probably the easiest way of getting activity into your daily habits, which doesn't have a significant impact on your pregnancy.
Okay, so it's much the same advice, and again, taking it in moderation.
Yeah.
And
So
not pushing
your way.
yourself too much.
Yeah.
Something I struggled with before the pregnancy was sleep. And I'm actually finding now I'm in my third trimester, it's getting a bit easier, I think, because I'm just more tired in general. But how do you advise women who have difficulty with sleep and pregnancy, and specifically with the position of sleeping?
So generally speaking, we advise that you try and sleep on your side slightly rather than on your back, all right? And you may need supportive pillows to help with that. And again, as with most measures, we would think about whether you can stop looking at your phone an hour beforehand, whether you've had something to wind down, for example, a bath before going to bed. So all of those gentle preventive measures may have an impact. If you are still drinking coffee and tea, when are you drinking them? Is that what's keeping you awake? Have you got any stressful factors that are going on? What time are you eating? All of those types of natural things can have an impact on the depth of your sleep and how easy it is to fall asleep. And those are easy things to consider before we look at whether you need anything to help you sleep in terms of medication. And we are generally very cautious in terms of recommending sleeping tablets, for example. There are natural remedies, and the supplements, which may be better to consider rather than plumping for medication straight away. But again, it depends. You may have had problems getting to sleep even before the pregnancy. So there you may be more reliant on regular medication than women who haven't had problems previously.
And actually on that subject, I have come across friends and colleagues who have mentioned that they've suffered with insomnia in their pregnancies where they haven't had any issues with sleep before. Do you get a lot of patients with that?
Yeah, absolutely, because things are changing, especially if your baby's awake at night. That can then have an impact. And remember, you've got a baby that's growing and pressing on your bladder. So again, going to the loo may be one of the reasons you're actually waking up. So it's really not uncommon as you approach your labour date to find it more and more difficult to sleep, feel hot when you are trying to sleep, not being able to get comfortable, and then on top of that, having to go to the loo and feeling baby move continually. So there's so many different issues and dynamics at play. And there, if you cannot sleep well at night, it is worth thinking about whether you need either extra time in bed over the weekend where you can make up for things, or a power nap later on in the day. And those are just simple adjuncts that you can consider at any point.
Thank you. So a common concern for mothers, especially in the third trimester, is sexual activity in pregnancy. Now, obviously, it's one of the things that people recommend when you're trying to get things going in terms of labour. But are there any instances where we should be avoiding sexual activity in pregnancy?
Yeah, absolutely. So there's a condition called placenta previa where the placenta is lying quite low. And there actually we do recommend that patients try and avoid having sex. And equally, if someone's had vaginal bleeding, one of the questions I'll have is that related to sex? And actually, is it better to avoid sex for a certain period of time to prevent that recurring, depending on how heavy the bleed was and the rationale for why the bleed actually happened. But certainly with a low-lying placenta or placenta previa, we would recommend avoiding intercourse because of the trigger of potential bleeding.
But if you don't have any of those factors or symptoms, is it safe to have sex right up until the end?
Absolutely. Absolutely. As long as you're both comfortable, you may have to adopt different positions, different techniques, but absolutely fine. All right. And again, there, respond to your body. If after sex you're having pains or bleeding, then perhaps it's time to look at whether you cut back or you look at different positions.
Great. That's really helpful. So we talked about a lot of the symptoms that you might face during pregnancy. Are there any really concerning or alarming, what we call red flag symptoms that we should be looking out for, especially in this third trimester?
So the same red flags that I mentioned earlier around abnormal vaginal bleeding and also tummy pains, regular tummy pains or ongoing rumbling tummy pains are particularly important. But other things that would make me think I need to see you now or sooner rather than later, if your baby doesn't move as much or stops moving, that to me would be something I'd like to get checked over. And any signs of infection, so that could be a foul-smelling vaginal discharge, or it could be pain on urinating, because as we spoke about earlier, if that's not managed early, then actually that could trigger premature labour potentially. So those would be the main red flags that I'd be thinking about.
And that's helpful that they are quite consistent throughout the pregnancy.
Absolutely.
So it's nothing new, essentially. No. So we've touched on the birth plan and how it's important to prepare yourself for what you'd like in your delivery. But of course, things don't always go to plan. So how do you support women when things change?
And I think preparation is absolutely key. So we talked about antenatal classes, we talked about antenatal appointments and the birth plan. And those are all initial opportunities to think about plan B or plan C. And start thinking, well, what if this doesn't happen? What if I need A, B, and C? And then actually, when it comes down to the critical moment of making a decision, when to deliver, if that's changing, or how you're going to deliver, having that two-way conversation, maybe even three-way, between you, your partner, the doctor, and even the midwife, all right, depending on who is available at the time and who you need to speak to, if not all of us, all right? And we're happy to take that conversation at the time and, where possible, give you some time to marinate on the change to make the best decision possible for you, be it a change in the timing to induce labour, or in fact whether we're changing from vaginal delivery to caesarean section. Now, in some cases it can be quite urgent if you're in labour already, and they're actually, I think, again going back to the antenatal classes and thinking about that possibility at that stage will serve you well for if there's a change in scene during labour.
So approaching my due date now, I am doing those final bits of reading. I've been so fortunate to have the uni journeys to follow and the podcasts, and of course have read some of your reviewed articles also. But beyond that, is there any must reads that you would recommend for people in my position?
I actually think that the basics of the NHS website, reading your notes, and the pregnancy information within your hospital will give you a really good base of what to expect. And there are so many different websites that support your week-to-week journey. I think Uni does that very well. Those would probably be my key starting points. And then the Department of Health's practical guidance in terms of employment, driving, etc., can supplement them from an everyday perspective. So it's not just about the health related information that we can give you, but actually the impact of having a baby on the rest of life. That is just as important. And equally, tapping into the advice that professionals are giving you along the way and making sure that you know of the nuances. For example, we mentioned MAT B certificates in the NHS are all really important supportive measures which you otherwise may not come across. I think the other thing to say is antenatal classes are a secret potential minefield where you get to meet other like-minded parents who are at a similar stage of your journey. And that's fantastic as a base foundation for support and exchanging ideas, information, and that should not be underestimated. Some of those people will carry you through not just your pregnancy and birth, but will become friends who your children then go on to socialise and do activities with in the future.
Thank you so much, Shree. I can definitely sympathise. I've learnt so much from the friends I've made in my antenatal classes already, and actually sharing those ideas and questions that you'd maybe have not thought of or you were too afraid to ask. It's a great place for doing that. Thank you. So I'll be asking you some personal questions, and I want you to answer them as quickly as you can.
Okay.
So first up, tell us about a hobby that you have.
Gosh, it's got to be yoga. Really just helps me unwind like nothing else. And it's not too strenuous, but just relaxing enough. So I would recommend it to everyone at any stage.
And fantastic in pregnancy too. So
Exactly.
I'm going to add that.
Exactly.
And if you were a boxer, what would your entrance song be?
God, it's got to be the classic. I'm thinking Rocky. I'm sorry, okay? There's nothing wrong with Rocky. A bit of Rocky.
No, that's it. Stick to the basics.
Yeah.
And if you had a superpower, what would it be and why?
That's really easy. I would love to read minds. Think of where you could be if you could just read what your patient was thinking. It'd be amazing, let alone everybody else.
You probably don't need them to come in.
Yeah, that's true. It might get a bit overwhelming if you can read everyone's minds, but yeah, that would be my number one.
That's a very good choice. Okay, so we're going to do a quick fire round now. So I'm going to ask you a this or that option, and I want you to say what comes into your head first.
Okay.
So, early bird or night owl?
More early bird, I would say, yeah.
And coffee or tea?
Decaf, coffee.
Okay, dine in or dine out?
That's a tricky one. Both can be good. So tonight, with this weather, dine in.
Okay. Yeah, good choice. Obstetrician or gynaecologist?
Again, Trixie, I would say now erring more towards gynaecology, actually.
Okay. And favourite ice cream flavour?
Oh, that's easy. Vanilla. Again, a classic.
Yeah, definitely. Good choice. And lastly, describe yourself in 3 words.
3 words? That's a tough one. Lots of fun. There you go.
Those were your 3 words.
Yeah.
I like that. Okay, thanks for playing. And with that, we've come to the end of our podcast today. So thank you so much, Shree. I have learnt a world of information from you, and, you know, from your journey where you've talked me through week by week what to expect. I feel after talking to you today, I am much more prepared than I was before. So thank you.
Fantastic. Very pleased to hear, and thank you so much for the invitation.
You're very welcome. I hope you'll come and see me after my baby too.
Would love to.
If you'd like to hear more, subscribe to uni.com to take our pregnancy journey and get week by week advice from Dr. Shree.